Good morning and welcome to yet another panel at FIS Week 21. It's an honor to participate in this edition. I'd like to congratulate Jose Villar. We're starting this panel about the epidemiology base for managing populational health. We have our colleagues with us, Dr. Julio Croda, infectologist and researcher at Fiocruz, and a professor at UFMS, Miguel Lago, executive director at IEPS, and Renato Veras, medical director at the Open University of UERJ. Epidemiology refers to the study of people, or the study of what happens with the population. According to the Oxford University Press Dictionary, epidemiology is the study of distribution and determinants or events related to health in specific populations, and the application of that study for controlling health problems. Maybe its precise definition is not as alive in your head as it should be, but the practical application of epidemiology is more present than ever. Populational studies, vaccine coverage, at-risk populations, syndromes, and a series of elements that are recurring in the media and that go way beyond scientific explanation. Epidemiology includes the study of sequence, patterns, causes, or events related to the health of populations, and the application of this study to deal with population health problems. In a country as big as Brazil, this study is fundamental as a strategy for managing the healthcare of populations from different origins and different contexts. It's a key practice to establish diagnosis, planning actions, and guaranteeing the distribution of resources to care for the health of a certain population. Thus, epidemiologists examine the occurrence of diseases and impacts on populations using cohort studies and cause and control to assess that. Basic, specific knowledge about the occurrence and dissemination of disease in a population is essential to implement effective measures for control and prevention. To get us started in the conversation, I want to invite Dr. Julio Croda for his initial words. You have the floor, Dr. Julio. Good morning, everyone watching us at FIS Week. It's a pleasure to be with such a large audience from several different industries in our society to deal about the subject that's not usually approached in this type of meeting, but one that's fundamental if we want to understand what occurred with COVID-19 and what we can expect for the future. Epidemiology is where we can somehow think about society, propose more effective prevention measures, especially to deal with infectious diseases, but also chronic diseases. So it's important that we bear in mind that without high quality education, there is no high quality treatment, there is no adequate control, there's no adequate preventative proposals, and you cannot work with population health. The epidemiological concept of several diseases leads us to think about the best interventions, the most effective treatments for that specific population, always taking into account the geographic location. We use epidemiology every day in our routine. For instance, the budget that's allocated to each state is based on the IBGE census that collects information about the number of residents in each city, their social economic characteristics in terms of income, age distribution, distribution by sex, and diseases that can be found in that population, such as the prevalence of diabetes, hypertension. Our census has been delayed. It should happen every 10 years. And without the census, we could be blind to understanding the population flows that occurred in our country For instance, the growth of certain cities and regions, the need to organize healthcare services that are necessary to cater to the needs of that population. And if there's been a change to the population profile in terms of income, age range, distribution by sex, and level of education. So we're lagging behind in this census, which is a reason for concern because we use it a lot for our daily activities as epidemiologists, because it gives us this scenario about the population, not only in terms of demography, but also in terms of healthcare elements that are essential for healthcare managers, both public and private, to make their best decisions. Brazil is a huge country with different realities, different healthcare hurdles. We know very little of Brazil, and therefore we waste many public and private resources because we're not able to plan adequately. We're not able to accurately define the reality of each location, and that somehow leaves us blind. And we've been using the census, which is very important for that, the IBGE census. We have to advance in terms of understanding some health aspects that are not found in the census. And that's why we talk about health surveillance that encompasses several sectors, one of them being epidemiological surveillance that generates information about diseases and about understanding the concentration of diseases in the territory and of proposing more cost-effective treatments. We clearly experienced the moment in Brazil where epidemiology showed its bases, and we that work in epidemiology, we understand why some scenarios occurred during the COVID-19 pandemic. And we could see during the pandemic that some cities were most affected, others not so much. Some states had a greater impact due to the pandemic, greater mortality, higher need of hospital facilities. And why does that happen? A clear example is the distribution of treatment beds in Brazil. There's a scarcity of that, especially in the north of Brazil. There is a scarcity of medical professionals and healthcare professionals in the north of Brazil, which somehow leads to an unequal offer of healthcare services and treatments, and somehow also leads to a consequence. The consequence of the COVID-19 pandemic was the tragedy that we saw across many states in the north, and more specifically Manaus. Everybody remembers what happened in Manaus, and that was not by chance that that tragedy happened. And the epidemiology can explain that. It's a city with low coverage of primary care, with a few intensive therapy beds, both in the public and private network. So it's not only a matter of poor management, but also in terms of the conditions that led to this chaos in the city of Manaus due to lack of infrastructure. When you compare it with states in the south, especially São Paulo, there's a relevant offer of hospital beds, and there was no shortage of these hospital beds, and therefore the management of the crisis management was more adequate, and some activities could be limited. You can have an impact, a lower impact on the economy. So it's really important to understand that epidemiology is the basis of everything, and that we have to get ready for the future. We have to get ready for new pandemics, and also to get ready for demographic changes that are going to happen in Brazil. Aging, increase in chronic diseases. These data are produced by epidemiology. Epidemiology is highly connected with geography. It requires understanding the context of population health, and both public and private sector administrators have to understand its reality and offer more adequate healthcare services for that reality, for that context, and always with the view at the striking regional differences in Brazil. If we look at Brazil as a country, we'll understand that Brazil fits inside Europe, or actually vice versa, and differences are really striking. And we can understand why the microencephalus cases caused by Zika were especially found in the Northeast, and we'll understand why there's a huge increase of HIV and TB in the South, why the yellow fever virus was able to migrate from the North to the South and Southeast currently, and how we can propose intervention measures. Vaccination was what occurred with yellow fever. As the virus migrated through different regions, the offer of vaccines increased, and now everybody living in the south of Brazil has to take the yellow fever vaccine. So I think that Brazil has a robust system, which is the universal health system in Brazil, which is found across the entire country. We know that this system offers primary care to private services of healthcare. You have to notify any diseases, but it is also necessary to invest more in the intelligence of the system, especially in its fluidity and its immediate response in terms of generating data, in terms of generating evidence, not only to report, but to make better decisions and to generate treatment, and especially to assess these interventions, these treatments, if they're timely. We have a lot of difficulty with the universal health system in Brazil, the public health system, and also the private healthcare system. We have a difficulty in assessing preventative measures in the healthcare treatments, basic sanitation, vaccines, which are to other industries, but that are highly prevalent in health, such as access to minimum income. So there is a lot of discussion, and healthcare surveillance involves the basis of epidemiology, and it's the most modern way for us to discuss population intelligence in health. There are fundamental tools to contain new pandemics. And we've experienced a COVID-19 pandemic that was disastrous, with a huge impact on health, with a huge impact on our economy. And we could have done better if we had used more adequately the epidemiological data in terms of proposing more adequate interventions, understanding each scenario of the epidemiology, each social context that we find, and these differences that we find in Brazil. So we could discuss in this scenario the availability of diagnostic tests for COVID, the availability of intensive care hospital beds, to understand that in some regions there's lower vaccine coverage, and what are the reasons for that, and how we could we have to offer. There's a need for a vaccination passport in some regions because the population is more, it tends to reject vaccination. So, well, I could keep on going, but there are other speakers. I'll give the floor to them. I will focus more on the epidemiological basis in their relationship with infectious diseases, but we can also discuss management and how epidemiology can contribute to administration. Thank you. Miguel, over to you. Thank you. It's really an honor to be here. I want to thank FIS for the invitation. I want to thank my fellow panelists, both Carlos, Dr. Julio, Dr. Renato. It will be hard to talk about epidemiology with Dr. Julio, but anyway, they're the specialists. But I think that a few things that, adding to what Julio said, one thing he mentioned was that the poor quality of our response to the pandemic was due to the fact that we were not necessarily using epidemiological bases as guidance for this response. And that's true. And I think that an even more important element has to be highlighted. Brazil developed over the course of the last 20 or 30 years one of the biggest programs in healthcare. And the family health strategy is a model recommended by the OECD, which is a club of rich countries that Brazil dreams of joining. But when it makes recommendations about public health, it includes the family health strategy as an example. And in that strategy, we have over 300,000 community agents spread across the country that have the trust of the community that they treat. And that's one of the most important elements of public health, the trust of patients, the trust of the population in those professionals. And it was not used adequately as a source of epidemiological surveillance. Back then, of course, it was very hard to do testing, and Brazil fell in the trap of global inequalities. So our testing capacity was impacted, and there was a series of problems. But we had this extraordinary structure that was not used, at least it was not as used as it should be, to identify and reinforce certain messages, and therefore take on this role of being responsible for epidemiological surveillance. So I think these are warnings for us. I think we can do a better epidemiological surveillance than we've been doing right now, because we have an extraordinary basis. Having such a prevalent system is not found anywhere. That's number one. The second thing is that the way healthcare is organized in Brazil, public healthcare management is organized is based on a political standpoint, much more than an epidemiological perspective. The way the public health system was set up in the Constitution gave a lot of flexibility to municipalities. We have over 5,000 municipalities in Brazil, and municipalities are guided much more by their mayors and their political stimuli in terms of building hospital or delivering healthcare facilities that could lead to a high number of votes, and not necessarily what that municipality really needs. So a rationale of epidemiology and population health that is able really to organize the healthcare systems is necessary. And of course, we understand that certain things are desirable, but they're politically unfeasible. And that's a huge political fight, because municipalities will not give up on their autonomy. But it's increasingly more important that municipalities are coordinated with other municipalities to create and organize the healthcare system based on the needs of that population, and not based on a political rationale. This is a role that governors can take on. And Espírito Santo, when Ricardo Oliveira was the health secretary, was able to better organize the system, strengthening the regional healthcare facilities. And that's possible, but it requires hard work and political leadership. So I think my main message is that we should make good use of what we already have to provide for an even better epidemiological surveillance and to base our healthcare policies on them, but also to think about how we can rethink the healthcare system, always based on the epidemiological base rather than the political and administrative base. That was my introduction. Thank you. Thank you. Thank you, Miguel. Dr. Renato, you have the floor. Well, first, I want to thank the FIS administration, my dear friend, José Villar. We worked together for many decades during PRONEP times. And well, I'll try to talk about the obvious, the extremely obvious things that should have been done, but we do the opposite. And that is necessary because this refers to the basis of a more effective system, and epidemiology is certainly fundamental. Well, my proposal is that we think about this in an absolutely simple manner, and everybody will agree with this. And hence my first question. We don't walk the talk, which is absurd. When we talk about essential healthcare models, of course, the elderly group needs to be given the most importance because it's the fastest growing group in Brazil. We have a huge amount of elderlies in Brazil, and we know that that tends to increase more and more. If we think in a very simplistic manner, in a big room, on one side of the room, we place 100 people aged between 85 and 90. And on the other side, we put 100 people aged between 15 and 20 years of age. And if we ask anybody, a passerby on the street, a layperson, and we ask them, what's the more fragile group, the one on the left or the one on the right? People will say, well, of course, the older people, they're much more fragile. And that's true because the elderly people are more fragile. They have chronic diseases and more diseases. And why is that so? Let's imagine a heart beating 70 times per minute for 80 or 90 years. Of course, that heart is going to be weaker. And that information is found everywhere. So the healthcare model that we need to find, which, by the way, in terms of healthcare models, broadly speaking, we have two big models, the American model of fragmentation and hospitals, or the British model from 1948, where there's this rationale of a GP and the physician will be the coordinator with his portfolio of clients. But when the population ages, it's even more important to coordinate care because there's a certainty that those people will develop a number of chronic diseases. So for that, you need to be based on a totally different rationale than the one that we adopt. We cannot have the emergency room as the entry door into the system. You cannot have a customer with 4, 5, or 6 physicians because he or she is a lay person. Well, I have pain in my arm or a cardiovascular problem. It could be a lung problem or a liver problem. So they start looking for physicians, whether it is in the public healthcare system or in the private healthcare system. And that is absurd because we cannot, we should not agree with that. And especially due to the low quality of healthcare and its inefficiency and its high costs, our healthcare system could be much better and much cheaper, taking better care of people, and especially the population that we know that will develop chronic diseases if we had, for instance, epidemiology tools, the screenings, which are highly accurate in terms of identification of 85, 90%. That's almost the same as physicians. But anyway, we do have simple tools, and we should have medical records that are much more intelligent and that are based on a follow-up methodology. A medical record cannot only talk about pathology. That person, do they live in a community? They have their family members. There's emotional aspects, nutritional aspects. There's rehabilitation that's required for the elderly. And that's why we work with gerontologists, the nurses and psychiatrists, so actually psychologists and nutritionists. I mean, it's a team which is what I call the light healthcare team. People that by caring for a certain healthcare portfolio, they get very good results due to the support that they give to that population. And actually, more than that, the support they give allows you to increase essential care and reduce costs. You can, for instance, have an average in a population of 7% of hospitalizations, and the cost of this population group that consumes around 60 or 65% of healthcare costs at a hospital, you can bring it down to 40% and have much more money to invest in lightweight healthcare with basic care, follow up, and use less this group of specialists, or as I said, to use less the hospital as the basis of the system. I am a physician. I am a professor. I've been doing this for a long time, so I'm not criticizing my colleagues. I'm not criticizing physicians. However, the excessive use of specialists is bad, and it's bad because you have a group of physicians and they prescribe drugs and they prescribe tests, and that's not kept in one single medical record. Each physician has their own computer. It's actually modern typewriters that people have, right? And they do not communicate between each other. So having a medical record that is really intelligent and that can be used by a healthcare system where the GP, the family physician, the generalist that coordinates the system, and if necessary, of course, they'll refer the patient to a specialist, but the patient will come back to the medical appointment, and that will be recorded in the medical record. The family has a fundamental role. When it comes to the elderly, we have to talk about the family and the people around that elderly, the people who are protecting them, and the people who are coordinating care at home as a routine, activities involving participation, new information. I mean, at the university where the project was created 20 years ago, it received an award by the WHO because we take on a very broad perspective and the need to produce science. I'm also an editor in a journal, one of the most important journals in Brazil in gerontology. So we need to find solutions that are absolutely different when it comes to our specificities. And the myth that elderly people are costly, well, they're costly because the model is bad. It's too fragmented. It's a model of high intervention and a few results. So these things, I would like to bring them to the table and place the epidemiology at the center of the stage, as well as the medical records and the way we follow up on patients and the lightweight care, as I call it, in the role of a healthcare team, not necessarily physicians.
Yeah, and I work with ANF, and Marta Oliveira, actually, who was director and so on and so forth. Marta was my PhD student, and it was all very interesting for the agency. We carried out a project defining the basis for the model that we thought was the best one. 118 companies participated. And then we had a selection, and as amazing as it may sound, very few had a model. For example, the old model in England where there is a manager that conducts everything with a well-qualified physician who's a well-trained. I'm not even getting to the details of other important aspects for the success, but I just wanted to show you that we are a bit schizophrenic. We say something and we practice something else. I don't know of any manager, and I know a lot of them. They all assure that in my system, I do have team management. We're all in favor of prevention, promotion of healthcare, of having a physician in charge. But then when you check it, unfortunately, that's not how it works. And so this is something I would like to reinforce. Aging is an issue. We're not going to go back in time. Brazil is no longer the country of the world. The whole world is aging. Our practices have to change. And we here in Brazil have to change our healthcare model. It's inefficient. And for the elderly, it is totally not qualified. We have a lot of chronic diseases, and the elderly end up being a problem for their families. We all want to live longer, but we want to live longer and healthier. If you're older than 80 and you have to go to the doctors every day carrying out tests and with 100 physicians at very high costs, that's exactly what we have to eliminate. I apologize for being so enthusiastic about this, but because I've been dealing with this aging issue for a while now, and something that I created some 20, 80 years ago, and we have the WHO with its guidelines, and we do a lot of things together with other countries. And so just to wrap up, I wanted to say that in the Netherlands, and Martha is carrying out a project here in Brazil. It's called Lago. She's even considering not having a doctor. I think that's perhaps a bit too radical, but we have to keep in mind that coordination is important. Care is very important. The families must be incorporated. A whole bunch of things that we don't do here. I apologize for taking more than my 10 minutes, and let's move on to the Q&A. I have encouraged questions, so let's move on. This is it for now. Excellent, Dr. Renato, and the energy and your excitement actually are both very important, because to have changes, we do need all of that energy. Let's move on to the Q&A. I would like to suggest that we start with Dr. Julio. You talked about what we experienced during the pandemic. You talked about the tragedy in the north of Brazil. And epidemiology can explain why it happened in the north region. My question is, will we be able to avoid a second tragedy with a new pandemic or a new situation like that? And also, what do we need to do that? Carlos, that's an excellent question. Thank you for the opportunity and the time to be able to clarify this specific topic. Now that we have effective mass vaccination, the population is complying, we are accelerating. Rio has an extremely high vaccine coverage in all age groups. We will be able to obtain vaccine coverage and obtain better results, but we have to define what was right and wrong. We should not have a political debate. The responsibility to manage this crisis is ours. Epidemiology is the basis, and it will help us understand why we had this tragedy, what are the indicators that justify it, and how we can better prepare for the future. In Brazil, we have a very good system. Our public healthcare system is wonderful. It is widespread. We also have healthcare services. We have quality data, actually. The US, for example, it's difficult for them to obtain data related to epidemiology and the number of cases and deaths and vaccination, because each state has a different notification system. And so it's difficult for them to generate combined data and to analyze information more substantially. We do have an advantage. We have a robust and strong system. We have good notification as well. We may have some underreporting, of course, but hospitalization and death, which is something that we used using SIM and 2 national systems, actually. Every hospitalized patient must be notified, and every patient who dies need a death certificate. So we do not have underreporting for deaths, as opposed to Mexico. They have over 50% of underreporting on the number of deaths. India too. We have a good information system. What we lack is a good strategy system to deal with emergencies in public health care. Our surveillance model, both at the level of healthcare surveillance, which means epidemiology for managers at a local, state, and federal level, do not use a lot of intelligence and do not use current tools such as math modeling to anticipate future situations, to understand the impact of an economic crisis, which is what we're going through now, to propose interventions, and to monitor by means of epidemiology and healthcare. Oftentimes, local managers want to expand their program, for example, to test tuberculosis. Great, wonderful. It's a disease that is concentrated in the more vulnerable population. So what do? They do not understand that in some towns, the main population are perhaps those who, the inmates. So we generate data, and in this case, we have a lot of cases of tuberculosis, dengue fever, and so if you have an approach which is related to the local reality, because you haven't used epidemiology to evaluate that and understand what is the best intervention, and you waste money and you don't reach your objective. Historically, our public healthcare system has always had good data collection, notification. Somehow we can monitor diseases, but we need to evolve. We know that some countries that have a strong healthcare service have evolved with their intelligence system. Every week we have reports with math models, robust analysis, where interventions are proposed to the government. Here for us, it is difficult to act based on intelligence. Perfect. Thank you, Dr. Julio. Also, adding to your comments, what you said about moving on with intelligence, I'm going to link it to what Miguel said. We have to change the way we analyze investments in healthcare. We have to change that to an epidemiologic basis. I asked Miguel, what kinds of incentives should we have in place? And he was talking about what happened in the state of Espírito Santo. So what can we do to have better incentives so that this intelligence-based information is used more effectively, and above all, in a proactive manner, not only to explain what happened, but to act so that we can avoid degrading situations. Thank you for your question. Espírito Santo did it by using leadership. We had a good communication process among the different parties in the different cities, and the state government always has its own budget. I know that one of their strategies was to locate or find and then distribute healthcare equipment so that all of these different regions could be better organized. And this is something that could happen with the state level governments, but we must have budget in place. I would like to remind you that our public healthcare system is the most ambitious healthcare system in the world because we have a very large population and offer free of charge. We offer healthcare free of charge. And we compare our data, Brazil invests 3.8% of its GDP in healthcare. This is almost nothing. It's a little bit more than Venezuela. And so if you consider Spain, for example, they spend over 7% of their GDP. And France, for example, has a better system than the UK. Their population is smaller, but they truly give a value in it. So we always have to consider how we're going to fund our public health care. And this is a chronic problem we have, actually. Very good. Thank you, Miguel. Dr. Veras, regarding the traps or the problems we have in our current system, you mentioned some specific examples and the incentives we have today, taking into account hospitals, and sometimes they do not provide adequate follow-up to the patient. So how do you see this? And also using what happens in geriatrics. So what worries you the most about our current system and about our current incentives? Carlos, what worries me the most, and I'm not going to start from scratch, otherwise I would need 3 hours. But let's talk a little bit about intelligence, for example. Information is essential. That is why we in public health care and those who deal with collective aging, as we like to call it, that's why we are so concerned about the patient report. So let's consider a patient with 3 or 4 chronic diseases, and they go to their doctors 5 or 6 times per month. So how many reports do you think these patients have? Hundreds of them. This is 2021. This is absurd. Technology is there. It's so basic. So we must have intelligence available to us so that we can take care of these actions that are quite simple, actually, but we need to have some logic in place. We need to start dealing with this issue, really. And another important factor is that we're talking about this as if it was something so obvious. But if it's so obvious, why don't you do it? We have an old model, outdated, and it is something that was created way back then, and it's not an efficient model. It's impossible for you to hope that people will change something that they have practiced throughout their lives. I, for example, when I have consultancy and create healthcare models, I will say, well, I want a doctor who has had a degree for at least 5 years. But I also do not want to have anybody who's had a degree for 30 years. Sometimes they are wonderful pneumologists or cardiologists, but they no longer have an overall view and will not include the correct team of doctors around them. People cannot think simply. If we know that most people, when they are as of 15 years of age, they will have chronic diseases, the same way that, nobody has a half of a disease. A woman cannot be half pregnant. So when we have a chronic disease in place, if we do not do anything about it, we can rest assured that it will get worse. And the problem is that we're talking about multiple chronic diseases. We're not talking about a single disease. So if we use a system where you have your own doctor who follows up the patient with all of the information required using epidemiology and with an intelligent medical record, with that alone, you can reduce costs significantly. You decrease hospitalization and hospitalization time, and you can offer better care, not only for the patient, but for the patient's lives, for the patient's social group. When we have outpatient projects, I had my PhD in England. So there are areas where we're not talking about patient visits only. We have lectures. It's almost like a healthcare club where everything is done in a pleasant manner. That's where you establish relationships, emotional relationships or relationships based on knowledge, and also in European countries where you have the winter time where all of the outpatient wards could be empty. It's the other way around. People go there, they receive meals there. So we have to conceive healthcare in a broader way. It is very expensive for a country to leave a huge population like we have, who are older than 50 years of age, a lot of them in a hospital bed, suffering with a lot of problems for their families. So like I said, getting to be 90 years of age nowadays is relatively easy, but we don't want people to suffer for 40 years after they are 50 years of age. And so to wrap up my intervention here, I wanted to reinforce. I have dear friends who work with healthcare, people who mean well. They say they practice in their companies, or sometimes they're even directors in different sectors of our public health care. They say they practice modern medicine. Well, it's a big lie. We are outdated. We we still use a lot of drugs, a lot of specialists, and a lot of testing. Once again, I'm not against a hospital. I'm not against the specialists. I am against excess and the inefficiency brought about our model. And the worst of all is that as our elderly population grows, we know the next year things are going to be worse than they are now. And I will stop here. Perfect, Dr. Renato. Okay, so let's talk to the audience. I have two questions, actually. We still have a lot of inefficiency. So how can we overcome this barrier? Also, COVID-19 infections, a new wave has started in England, and how are we going to face that? Well, it's important to characterize, and I will start with the second one because the first one is part of the consequence of the second question. So whenever we look at Europe, we can see Germany, for example, they have a vaccine coverage of 68, and here in Brazil, we have similar dates. The first dose is 76 or 77%. So in terms of the first dose, we're doing better than Germany, but in terms of the second dose, we are behind them. Whenever we talk about Germany, we have Austria and neighboring countries that have a low coverage. And then when we look at the Soviet Union and Russia, they also have low vaccine coverage. In this new European wave, we can divide countries into two groups. One where you have an increase in the number of cases, but there is an expressive number of increases in hospitalization and deaths. And we have Spain, Portugal, and the UK. And we have other countries where the increase in the number of cases has had an increase in the number of deaths. The coverage is below 80%. And we know that in Eastern Europe and in the former Soviet Union, Russian, why is that happening? These countries do have vaccines available. They have bought their doses, and actually Russia produces the Sputnik and it has sold large amounts of doses to Latin America, but there is a lot of resistance to the vaccine. There is a strong anti-vax movement, and this is associated to the flexibilization of the preventive measures. The use of masks is no longer mandatory, but the increases in hospitalization and that's with a higher impact on the society, which can somehow revert these measures that were made flexible because people do not believe in the vaccines, and because of the strong anti-vax movement, which was very strong in Russia actually. And in these regions, this is done, or this happens because of a more totalitarian regimen. Here in Brazil, it's the other way around. We have had excellent vaccine coverage because in surveys carried out in the Americas, Brazilians accept the vaccine more. 94% of our population accepts the vaccine. And so we cannot allow any arguments against vaccine to be expanded. We have reached the situation in Brazil right now, not because of any governor, mayor, or the federal government. It is happening because our population is complying with the vaccination system, and some countries, or some people do not support mass vaccination. They say that if you get the vaccine, you will be transformed into an alligator and things like that. But I think it is very important to request a vaccine passport as it happened in Rio, but we have to improve our communication. The wealthy countries are being penalized by the lack of information or disinformation spread in the social media. In Brazil right now, in some point in time, part of the federal government, and it's sad to accept this reality and to understand it. But fortunately, the Brazilian population rejected that kind of argument, rejected the anti-vax movement. The population is being vaccinated and is complying with the mass vaccination system. That brings a lot of hope. We expect that it will continue like that. We hope to vaccinate our children, guarantee collective vaccination, that our companies can start working again. That is excellent, Dr. Julio. So we are about to wrap up right now. I will try to ask Miguel to quickly talk about something that you cannot say in 30 seconds, but I would like him to quickly answer this question. So how can we use a single basis with integrated medical information so that we can reduce waste and decrease our current expenses? Is this a matter of public health care? Yes, it is, and it's very important. It's important to have unified information systems that belong to the patients and not to the companies or the government. That's essential. However, that's difficult. It's difficult to implement it from a technical point of view and also from an administrative and political point of view. The US spent a lot of money with their urban management trying to unify their information system, and it didn't work out. Estonia also has a success case. Australia also is a success case, but their countries are much smaller. This question is perfect. We should try to get there. Very good. Okay, so we are only 20 seconds late, but we had a wonderful discussion. I would like to thank Dr. Croda, Lago, Veras, and Marinelli for participating. And I would also like to thank you for being here so that we can prepare ourselves for the future. I wish you a wonderful event, and I hope to see you in another